Hi, Dr. Russ here. Today we have Sitka, who is having some pain in her right knee, which goes back a ways and we think maybe involves her right ankle as well. So tell me what's going on.
I've been dealing with this soreness, like really just chronic, constant soreness in my right knee for the last several months. And I think it was triggered by working out and doing squats. And I think it's correlated to a whole bunch of other long-term issues with my right ankle, my right arch, my right calf that have been going back like 15, 20 years at this point.
Is there any numbness or tingling in your leg? To ask about that.
No, at the moment, no. It feels okay right now. Like it's been one of those things that kind of comes and goes in severity, and I feel like it's a little bit more milder right now in terms of like overall like discomfort. It's not too bad right now.
Okay, thanks. Well, let's start with you standing. So we're going to look at her standing first, and this is the affected side, and this is the symptomatic area in here, as well as tightness down the lateral calf occasionally. We see a little bit of pronation of the right foot. Both of them are slightly pronated. The right one a little more. Otherwise, her feet look great. Great alignment of the toes, really nice spread of the toes. Just a little bit of a matter of loss of strength and integrity in the medial ankle. And if you turn around, that's often a lot more visible from behind. And you can really see the angle of the talus right here. So here's her calcaneus. And you can see the talus has slid medial a little bit. It's lost a little bit of support here. And the main muscle here that does this is the tibialis posterior, which originates way up here and comes down around like this, posterior and inferior to the medial malleolus, hooks into the medial arch, and it's really the main muscle that's supposed to be supporting her here. So that's on our mind, and we're going to be looking at tone and texture in that muscle. Otherwise, things look quite normal. Maybe a little bit of hyperextension of this knee. If you look at the crease, it's a little bit deeper on her left knee, but there's no swelling, there's no atrophy, which is all good. And can you just come up on your toes and stand on your toes for a second? Feel free to balance yourself on something if you need. And the muscle development is nice and symmetrical. She's really stable through here. That's something that is really good to see. So I think the strength and the muscle development is there. It's probably just a matter of engagement and maybe alignment or maybe some old injury in the ankle. So with that, let's have you face down and we'll look at knee movement. And we're just going to bring it through its main movement, which is flexion. And we can see the full range of flexion is there. And there's not a lot of resistance to it. And there's no clunks. So that's good. We want to make sure there's not anything clunky. That secondary movement of the tibia is this rotation, which we want to see, and we do. So the joint movement is good. It's smooth, and it's definitely adequate. And we're just palpating for swelling and to see if anything kind of jumps out at us as abnormal, which it does not. So everything here so far is a normal knee. Just palpating down the calf here. We like to see good movement between the gastroc and the soleus, and nice tone in the medial calf, and we have that. And that's really good. I'm definitely taking note of some lateral calf tension. Here as the soleus kind of pops out from underneath the gastroc, and we'll get back to that in a minute. Now let's feel for this ankle mobility. And we've got a little bit of tension here. So not quite as much dorsiflexion as I like. And I can palpate that tension as kind of being centered deep to the gastrocnemius and soleus, probably more in the toe flexors, that deep stuff. And inversion, eversion is definitely adequate. And it feels like her fibula glides pretty nicely with dorsiflexion. We'll show that in just a minute when you're on the other side. So here's her calcaneus, good play. Talus, her feet are very muscular. There's a lot of good strong muscle in here, but I definitely am feeling a little bit of trigger point activity here. So as that tibialis posterior tendon comes right under, sometimes you get trigger point at the attachment there. And then this muscle here, the abductor of the big toe, abductor hallucis, is right here. And in cases where that medial arch has lost a little integrity, you can see a lot of issues with that muscle because it gets overstretched. So some footwork is probably in order here today. Right here. I've got her fibular head right here. And as I dorsiflex and plantar flex her foot, I like to see a little movement there. And it's just barely like 1/4 of an inch. But look at the top of her fibular head right here. Inferior, superior. See that glide? That's a really important movement to the integrity of the whole knee. And hers is working. So whatever's going on, I don't think it's a very deep-seated problem. And it probably is more related to the increased stress that you've been putting it under with squats and deadlifts and stuff, which I just want to emphasize, those exercises are great. And that's not a problem that you're doing that. It's just brought up a little bit of dysfunction in the knee and ankle. And so that's something that we can address now. And so here, the lateral head of her gastrocnemius right here is really tight, and there's a little bit of adhesion to the soleus right here, and the origin of her tibialis posterior right here, actually very slightly grainy right there, getting a little bit of trigger point activity there. Okay, so we're going to start with some treatment here, and then down here in the medial arch of your foot, okay? Then we'll turn you over, we'll look at the knee itself and where the symptoms are. As usual, when we start skin level. We don't want to skip any layers. And let's remember that that lateral head of the gastroc, that's our target, that crosses the knee. And that's going to insert into the distal femur. On her, we can follow that tendon right there. Okay, so we're going to start at that attachment. We flex the knee a little bit to get a little slack in the fascia so that we can get through. Okay, and you can see I'm kind of pulling that iliotibial band aside a little bit and getting my finger medial to it. All right, we could come at it this way, but then we're working through a lot of dense tissue. So let's do it this way, yeah. So stroke's going superior as I extend the knee, so we're getting a little glide of the tendon under the finger, and we want to feel that smooth all the way up. And I'm going to bring that all the way to that hamstring tendon where that transition takes place. And we don't want to overwork it. We just want to get some mobility and circulation. And now here we are a little bit more in the belly of the muscle. And this is feeling a little bit knotted right there. It's actually kind of a big knot right there. So just taking both of my hands to just kind of begin to define this knot for her. And so there's a few things going on here. One is we're literally squeezing out stagnant, congested lymph and venous blood. We are giving stretches to the tissues on a cellular level as well as on a gross level. We're also creating awareness in the nervous system of this knot. So the sensation of the treatment is an important part of the treatment. It's really good and productive for the nervous system to be made aware on a gross sensory level that this is happening. Take a deep breath here, Sitka. Good. Thanks. And so you can see the little bit of a stuck slip right here, and we're going to mobilize that. And this stuff can be really tender, so it's challenging for the patient. And this area can be challenging for the practitioner too, because the deep fascia in the calf is so thick and so dense. So it's like, 2 or 3 millimeters thick and tough like leather. And you can hurt your thumbs working through it. And the key is to take your time and not push too hard. So now I'm a little deeper, and you can see I'm anterior to the gastroc and the soleus, right on the posterior part of the shaft of the fibula. And we're coming up, finding some attachment trigger points on that tibialis posterior. Now, I do not think that we're going to, quote, fix her arch by working on this muscle. What we're going to do is help take some of the stress off of the knee that is caused by a little bit of pronation in her right foot. And I know that she's doing a lot of work really diligently to improve her lower body strength and function, and we're going to trust that process, and we're just going to help it along here a little bit. So remember, we had seen a little bit of resistance to dorsiflexion that was coming from the deep flexors, and I'm checking back in with that, and I feel like working that gastroc and working that tibialis posterior has improved that a little bit, but we're going to take it a step further. So I've got my grip here a little bit, one finger on the medial and one finger on the lateral side, just at the junction of where the gastroc and soleus meet the Achilles tendon. You can see on her, it's really, her muscles are so well developed, it's really evident that that junction is right here. So I'm a little bit proximal to that junction, and I'm lifting up the gastroc and soleus a little bit toward the ceiling so that I can get a little space and get my fingers right there, trigger point on the toe flexor. Can you wiggle your toes for me, Sitka? Yeah, and when she does that, I can feel that muscle engaging. So I know we're on a toe flexor here. And again, circulation, mobility, neurological stimulation, that's the key, right? And we felt that let go a little bit. That was good. So let's kind of just follow that. Now we're fully in front of the Achilles tendon. Very tough, thick tissue. And I don't want to hurt my thumbs, but you can see my thumbnail's white because I'm putting a lot of pressure here.
Oh my God. Whoa.
What are you feeling here?
Whoa. This is like, oh my God. Oh my God, this is so intense. Whoa.
Do you need a break?
No. Wow. That is the spot. Wow.
Coming into this area of the tibialis posterior tendon. It's actually moving really nicely through the tarsal tunnel, which is the space between the calcaneus and the medial malleolus, and bringing it, this palpation, right to its insertion on the medial arch right here. And that's a little bit firmer than I think it should be, but not tremendously. And remember, this is sensitive stuff, so we're going to take our time. You see a little bit of a twitch right there. Good. And a little easy mobilization here of her plantar fascia. Okay, well, she's nice and relaxed, which is good. So let's see about the range of motion of the knee. And as I lift her foot, I do sense a little bit of excessive extension through here. So I wouldn't call that unstable, but I would say maybe a little bit of excessive extension. And let's look at flexion from this position. Again, it's full, but I'm not just interested in the gross range. I want to feel the glide of the tibia under the femur, medially and laterally. So I've got my middle finger on the medial plateau and my thumb on the lateral plateau of the tibia, and I'm bringing it through its full range of motion. It feels really good. It was really nice movement. Good for you. So I'm thinking more about patellar position, tracking, and maybe some swelling underneath the patella. And then we're thinking about maybe some of the pain being generated by this tendon, which becomes the pes anserine. So it's gracilis, sartorius, and semitendinosus right here, three together. And that's going to insert right here on her. It feels normal. It's not swollen. Texture is really good. So I don't think this is a really bad problem. And it just feels like a little stuck and congested right here. Yep. Okay. So I'm going to sit down and we're going to work that through. Okay. So I've got her, basically her medial thigh distally here, feeling the adductor magnus with my pointer. I've got the vastus lateralis here with my thumb right there. And so all this tissue is the distal gracilis, sartorius, semitendinosus. And I'm really interested in it being just a little bit more pliable than it is. Okay, and as I get in there a little deeper, I start to feel, particularly on the posterior edge right here, some just a sense of restriction, and it feels a little dry, like the circulation is a little bit has been a little bit impeded there. So always circulation. Blood is really the thing. So I'm giving a nice stretch, pulling it toward me, rolling the tissues under my finger a little bit. My thumbs are acting just as counter pressure. And we're going to bring that treatment down, down. Here we are right at the knee joint line, or a little bit superior. Yep. So it does feel like that's the hamstring tendon, the most posterior of the three. That's being the most problematic. And there it goes. It just let go. Right there. Good. Following that, just the posterior border of the pes anserine, right here, all the way till it attaches to the tibia. Good. That was good. That was fruitful. We're going to do that again, okay? Okay. So now it feels like the anterior is its turn. So now my pointer finger behind is kind of just giving the counter pressure, and it's my two fingers, my ring finger and my middle finger, that are providing the pressure here. Coming behind the pes and then taking this whole thing and stretching it out toward the camera. Yeah, that's it. Make some space, stretch the tissue, get some blood in there. We don't want to overwork it. We don't ever want to grind on these tissues. It's really more about stretch. And when you're doing compression, you want to be gentle. Good.
Yeah, it's been so sore and stiff recently, though, that I've been concerned that that I was going to injure it further. Yep. And that it was going to get worse.
I'm glad you came in to have it looked at.